When you look at a geopolitical map, you kind of expect the borders to be absolute.
Right, like a thick black line.
Exactly. Without a doubt, where one country ends and the next one begins. And I think we tend to expect the map of the human body to work the exact same way.
Oh, absolutely. It's definitely comforting to view our anatomy through that, that really precise lens. We want our biology to be neatly categorized and universally agreed upon by the people treating us.
But then you zoom in on the final 6 inches of the human digestive tract, and suddenly that neat little map just completely dissolves.
Yeah, it really does. The cartographers are fighting, the borders are intensely debated, and
the historical labels we use are, quite frankly, just completely wrong.
Completely wrong.
So welcome to today's deep dive. We are so glad you're here with us. Today we're unpacking a stack of medical terminology notes that define the very end of your digestive system. Specifically, 3 little root words, right? Procto, recto, and ano.
Which, we so often think of this region as just one simple, isolated exit tube.
Right, just basic plumbing.
Exactly. But the reality is that it is a highly complex, incredibly delicate anatomical neighborhood.
So it's not simple at all.
Not at all. In this specific area, millimeters can dictate whether a cancer is curable. And understanding the microscopic wiring of a single biological border can literally mean the difference between a quick, painless office procedure and weeks of agonizing pain for a patient.
Wow. Okay, so we're going to look at where these words actually came from, the massive clinical battles over where these organs begin and end, and a surgical breakthrough that proved deeply understanding your anatomy can sometimes save more lives than $1 billion drug.
Which is an amazing story.
It really is, but, we have to start with the words themselves, right? Because we really can't grasp the science until we understand the bizarre history of how this area was named.
Yeah, you have to look at the language first.
Right. So we have this trio of roots. First, ano, referring to the anus. And this one is entirely straightforward. It simply means ring or circle in Latin.
Yeah, it's a direct, literal description of the circular opening.
Makes total sense.
It does. And it really hasn't shifted much in meaning across, 2,000 years of use. It is just a strictly functional descriptive term.
Okay, but then we have procto, which comes from the Greek word proctos, meaning the hindmost part. It basically functions as an umbrella term for the anus and rectum together.
Right.
But the real anomaly here is recto, for the rectum. The last, 12 to 15 centimeters of the large intestine?
Roughly, yeah.
So the root comes from the Latin word rectum, meaning straight. But as the notes point out, the human rectum is anything but straight.
It is one of anatomy's most enduring historical mistakes, honestly.
Wait, really?
Oh, yeah. If you look at the human rectum, it first curves backward and then forward to follow the concave sweep of your sacrum.
Okay.
That's the sacral flexure. Then it has this sharp, almost 90-degree side-to-side bend near the pelvic floor.
Like a literal right angle.
Pretty much. That's the perineal flexure. And even inside the tube itself, you have 3 horizontal, crescent-shaped folds of tissue.
The valves of Houston, right?
Exactly. They act almost like internal speed bumps.
So it bends back, it bends sideways, and it has internal shelves. How in the world did this highly convoluted structure get labeled the straight intestine?
Well, we basically owe that to the early anatomists, primarily Galen of Pergamon back in the 2nd century.
Right. His texts were like the ultimate authority.
They were treated as absolute gospel for over a millennium. But you have to remember, human cadaver dissection was heavily restricted for centuries, due to religious and cultural taboos.
Oh, so they weren't actually looking at humans.
Exactly. Early physicians inferred human anatomy from the animals they were legally allowed to dissect. Barbary macaques, pigs, dogs, other quadrupeds.
And in those animals?
In those animals, the terminal large intestine really is a relatively straight tube leading right to the exit.
Wow. So when Renaissance anatomists, like Vesalius, finally started doing widespread human dissections in the 1500s and saw all these complex flexures and folds, they just kept using the pig anatomy name?
Basically, yes.
That is wild. It's like buying the blueprint for a simple storage shed, building a 3-story Victorian house instead, and just insisting on calling the house a shed just because of the original piece of paper.
That is a great way to look at it. Medical terminology is just littered with these linguistic fossils.
It's so strange.
Well, the words don't always capture the objective reality of the biological structure, They capture the state of human knowledge at the exact moment the naming convention locked in.
Which is fascinating when you look at what happened to the root procto. Because unlike recto, which sort of survived based on tradition, Procto had a major collision with modern American culture.
Yes, it did.
Because as you noted, Procto doesn't map cleanly onto one distinct organ. It's more of a field-level route.
Right. It is used much like cardio in cardiology. It denotes an entire physiological neighborhood, like the whole lower GI tract.
But I mean, you almost never hear a doctor introduce themselves as a proctologist anymore.
Not today, no.
Our sources highlight this massive historical shift. In 1934, the American Board of Proctology was established to certify highly specialized surgeons for this exact area.
Right.
But fast forward to 1961, and they actively rebranded themselves as the American Board of Colon and Rectal Surgery. And the reason was that American pop culture had essentially turned the word proctologist into, well, a crude, faintly obscene punchline.
It really demonstrates how deeply language impacts the actual delivery of patient care.
Just because of a joke.
Yeah. The profession realized the term itself was actively hindering recruitment into the specialty, and far more importantly, it was damaging patient trust.
Oh, people were embarrassed.
Exactly. People were just too embarrassed to seek care from a quote-unquote proctologist. So the board basically erased the professional identity to save the discipline.
That is incredible.
Now, the anatomical route survives in precise clinical terms, right? Like using a proctoscope for an examination or diagnosing proctitis for inflammation. But the title on the doctor's door, that had to evolve.
So, okay, if the surgeons treating this area change their title to colon and rectal surgery, you would assume they at least have a rock-solid universal agreement on where the colon ends and the rectum begins.
You would think so.
But looking at these clinical guidelines in our sources, they absolutely do not.
No, they don't. And this is where the anatomy transitions from, like, historical trivia to high-stakes geography.
Right.
The border between the sigmoid colon and the rectum is called the rectosigmoid junction. And depending on which medical society you ask, or even which continent you are practicing on, the definition of that border physically moves.
That is just so counterintuitive to how we think medicine works. Our sources show several competing ways to draw this map.
Yeah, it's all over the place.
Some guidelines state the rectum begins exactly 15 centimeters up from the anal verge, right?
Yeah.
Measured rigidly with a scope.
Right, the rigid measurement.
But others define it anatomically, looking for the peritoneal reflection, which, for you listening, is where the shiny membrane that covers your abdominal organs stops covering the bowel.
Exactly.
Still others look for where the tenia colae, those three distinct muscular bands running down the colon, where those fuse outward into one continuous muscle layer. And some surgeons just use a bony landmark, drawing a horizontal line from the sacral promontory.
Yeah, it's a mess.
But let me ask you, does a millimeter here or there actually matter to the patient? Is this just an academic quibble?
Oh, it matters immensely. The clinical reality is that this lack of consensus genuinely alters lives.
How so?
Well, let's say a patient has a tumor sitting right on that contested, blurry border. If a hospital uses the 15-centimeter rigid measurement, you might be diagnosed with colon cancer.
Okay.
But if they use the peritoneal reflection, that exact same tumor in the exact same spot might be classified as rectal cancer.
And the treatment protocol splits completely based on that one classification.
Entirely. Rectal cancer, unlike colon cancer, typically requires neoadjuvant radiation before a surgeon ever touches you with a scalpel.
Why is that?
Because the pelvis is this tight, bony bowl crowded with critical nerves and the bladder. Surgeons need the tumor shrunk as much as possible before operating in that tiny space.
Oh, wow.
Right. But colon cancer, sitting higher up in the much more spacious abdomen, generally goes straight to surgery without radiation.
So a millimeter discrepancy in how a doctor defines that junction literally determines whether a patient undergoes winds of intense pelvic radiation therapy.
Yes, exactly.
That is staggering. And it seems like it would create absolute chaos for medical research, too. I mean, if an oncologist in Japan defines the rectum using the peritoneal reflection, and an oncologist in the U.S. is using the rigid 15-centimeter rule.
It actively muddies international clinical trial data.
I can imagine.
Yeah, a major rectal cancer trial in Europe might be testing a chemotherapy drug on a cohort of patients that an American hospital would flat out classify as having colon cancer.
That is a statistical nightmare.
It is an ongoing statistical nightmare for oncologists trying to compare survival rates across those different geographical definitions.
Okay, so the top border of the rectum is blurry, debated, and highly subjective. But if we travel a few inches further down into the anal canal itself, we hit a microscopic border that is shockingly rigid.
Very rigid.
An invisible line that dictates exactly how your body experiences pain.
The dentate line, also referred to as the pectinate line.
Right. The notes describe it as a zigzagging, invisible seam sitting roughly 1 to 2 centimeters inside the anal canal. The best analogy I could think of is like the channel meeting in the middle of the English Channel.
Oh, that's a good way to picture it.
You have two completely different engineering teams, right? One digging from France, one from England. And they finally fuse in the middle. They bring entirely different wiring and plumbing with them, and they just stitch it together at this one specific seam.
That captures the embryological mechanism perfectly.
Really? How does it happen in the body?
So, around the 7th week of fetal development, your hindgut, which forms from the inner cell layer called the endoderm, is growing downward.
Downward.
Right. At the exact same time, an external depression of tissue called the proctodeum formed from the outer ectoderm layer that invaginates and grows upward.
Meeting in the middle.
Exactly. When the membrane between them finally ruptures and they fuse, they create the dentate line. You effectively have two entirely different biological systems permanently stitched together.
So if the top half is an internal digestive organ, and the bottom half basically grew inward from the exterior of the body, they must be wired completely differently.
They are fundamentally different. Above the dentate line, the canal is lined by glandular mucosa, just like the rest of your intestines.
Okay.
It's supplied by the superior rectal artery, and its lymphatic fluid drains upward into the deep abdominal lymph nodes. And most crucially, it has visceral innervation.
Meaning what? For pain?
The nerves there only respond to stretch. They do not register sharp pain at all.
But below the line, the engineering flips.
Completely flips. Below the dentate line, the tissue transitions to squamous epithelium, which is biologically identical to the skin on your arm.
Wow. Skin on the inside.
Essentially, yes. Its blood comes from the inferior rectal artery, and its lymphatics drain downward into the superficial nodes in the groin. And because it is essentially skin, it has somatic innervation via the pudendal nerve.
So it feels everything.
It is exquisitely wired for sharp, localized pain.
Which explains so many of the common, incredibly painful ailments people suffer from, because the top half can't feel sharp pain, right? So if you have an internal hemorrhoid above the dentate line, a physician can tightly band it or inject it right in the office, and you barely feel anything more than a dull pressure.
Exactly.
But if you have an issue below that line...
A physical issue below the line is agonizing. The classic example is an anal fissure, which is a small linear tear in that squamous lining.
And because of those nerves...
Because it is wired with thousands of somatic pain receptors, patients consistently describe the sensation of an anal fissure as feeling like passing glass.
Passing glass? That sounds awful.
It is a phrase clinicians hear constantly.
Which brings us to the underlying mechanics of the sphincter muscles themselves. Because understanding how those muscles work explains why that passing glass pain is so hard to cure. There are two distinct muscles controlling this area, right?
Yes. Continence relies on a two-sphincter system. You have the internal anal sphincter, which is smooth, involuntary muscle.
Involuntary, so it works on its own.
Right. It's essentially a thickened continuation of the rectum's circular muscle wall. It stays contracted at baseline, providing up to 85% of your resting pressure. You never have to consciously think about it.
And the other one?
The external anal sphincter is a skeletal voluntary muscle. That is the one you consciously clench when you need to hold it until you reach a bathroom.
Okay, so let's look at what happens when you get an anal fissure, that painful tear below the dentate line. The tissue tears, the somatic nerves scream in pain, and in response, that involuntary internal sphincter goes into a severe reflex spasm.
It just clamps down. Right. But by clamping down so hard, the muscle actually cuts off its own blood supply.
Exactly. It induces localized ischemia. The oxygen-rich blood just can't reach the site of the tear.
And without blood flow, the tear can't heal. So the pain causes the muscle spasm strangulates the blood supply, the lack of blood stops the healing, and the open wound causes more pain. You are trapped in a biochemical feedback loop.
It's a vicious cycle, which means treating an anal fissure requires breaking the loop.
You can't just put a Band-Aid on it.
No, you can't just apply a soothing ointment to the tear. The medical intervention actually involves using topical nitroglycerin, calcium channel blockers, or even injecting Botox directly into the internal sphincter
To freeze the muscle.
to temporarily paralyze or relax that involuntary muscle. Once the spasm breaks, the blood flow returns, and the tissue finally has the resources to repair itself.
That is just brilliant. You use the anatomical wiring against itself to force a cure.
It really is elegant.
And scaling up that kind of deep anatomical mastery is exactly how the medical field revolutionized cancer treatment in this area. We're going to dive into a massive surgical breakthrough next. But first, we really need to clear out some widespread, highly dangerous misconceptions about this anatomy,
Yes, definitely.
starting with the idea that hemorrhoids are abnormal growths.
It is a pervasive myth. People tend to think a hemorrhoid is like a tumor or a polyp, like a foreign mass that shouldn't be there.
But they're natural.
The biological reality is that everyone is born with hemorrhoids.
Everyone.
Everyone. They are normal vascular cushions of connective tissue and blood vessels sitting right around that dentate line. They act like soft, internal pillows that engorge with blood to help seal the canal and maintain fine-tuned continence.
So they only become a medical disease when the structural support degrades and they become swollen, prolapsed, or thrombosed.
Right. The term hemorrhoids in a clinical setting refers to the pathological swelling, not the mere existence of the vascular cushions.
Which I think directly feeds the second major myth, that fissures and hemorrhoids are essentially the same condition.
Oh, absolutely. Since they both present with pain and bleeding, patients conflate them all the time. But physically, they're completely different mechanisms.
Right, because a fissure is a literal laceration in the skin-like lining below the dentate line.
And a hemorrhoid is a swollen structural cushion. You just can't treat a laceration the same way you treat a swollen vein.
Exactly. And perhaps the most dangerous misconception of all surrounds routine cancer screening, specifically the digital rectal exam, or DRE.
This one is so critical because it fundamentally misunderstands the scale of the anatomy.
Patients will go in for their annual physical, the doctor performs a digital rectal exam using their finger, and the patient walks out believing they have just been thoroughly screened for colon cancer.
Right.
But, I mean, if a clinician's finger is only 7 to 8 centimeters long and the entire large intestine is roughly 150 centimeters long,
The math just doesn't work. The DRE can assess the posterior prostate in men, and it can palpate the very lowest distal centimeters of the rectum for low-lying masses.
but the rest of it.
The vast, vast majority of colorectal cancers arise far beyond the physical reach of a human finger. Historically, the medical community over-relied on the DRE, giving patients this completely false sense of security.
So it's not a substitute.
It cannot, under any circumstances, substitute for the comprehensive mucosal evaluation of a colonoscopy.
Okay, so we know a physical exam can't reach high enough to catch most cancers.
Yeah.
Let's talk about what happens when cancer is found in the rectum, because our sources highlight a surgical revolution that completely changed the survival odds.
Yes.
And it didn't involve a new chemical compound. It involved a single surgeon realizing everyone else was cutting the tissue wrong.
You are referring to total mesorectal excision, or TME,
Yes?
pioneered by a British surgeon named R.J. Bill Heald back in 1982.
Because prior to 1982, the standard approach for removing rectal cancer was known as blunt dissection. Surgeons would essentially use their hands to bluntly tear the rectum away from the surrounding pelvic structures.
Which sounds brutal.
It does. And the local recurrence rates for the cancer were devastating. They were running as high as 25 to 40% in many institutions.
The fatal flaw in blunt dissection involved the mesorectum.
What exactly is that?
It's this thick, fatty envelope of tissue that entirely encases the rectum, and it contains all the draining lymph nodes and blood vessels. And microscopic deposits of cancer cells, they love to migrate into this fatty envelope.
Oh, I see.
So when surgeons blindly tore the rectum out of the pelvis, they were inadvertently shredding the mesorectum, spilling those microscopic cancer cells directly back into the surgical cavity.
So Heald analyzes this and proposes a radical shift. He basically tells the surgical community to stop tearing and start cutting. He advocates for using sharp dissection scalpels and precise surgical scissors to carefully navigate down a very specific natural anatomical boundary called a fascial plane. He actually called it the holy plane.
Heald recognized that the mesorectum is contained within its own delicate fascial wrapping. If you meticulously respect that fascial plane, you can lift the entire rectum and its intact fatty envelope out of the pelvis as one unbroken package.
You never breach the container.
Exactly, which means you never spill the cancer cells.
And when Heald first published this, the establishment pushed back hard, didn't they?
They did. They thought he was crazy for taking so much longer in the operating room to do this painstaking millimeter by millimeter dissection.
But the data was undeniable.
Completely undeniable. As the TME technique was audited and adopted worldwide through the 90s and 2000s, local recurrence rates plummeted from that 25 to 40% range down to roughly 5 to 10%.
It is just the ultimate testament to anatomy outperforming chemistry. By simply respecting the natural fascial planes defined by embryology, Healed saved countless lives without introducing a single new drug.
It's an incredible legacy. Though, as we look at the current clinical landscape, there are new frontiers in this region where updated protocols are desperately needed.
You mean the shift towards standardized anal cancer screening?
Precisely. We spend a lot of time on rectal and colon cancer, but squamous cell carcinoma of the anal canal, which arises right at that dentate line we talked about, is a different biological entity.
How so?
The vast majority of these cancers are driven by HPV, the human papillomavirus, much like cervical cancer. This is particularly prevalent in immunosuppressed populations, such as those living with HIV.
And the 2022 Anchor trial is a huge focal point in the sources regarding this. For years, clinicians debated whether they should be performing high-resolution anoscopy and routine swabs, essentially anal pap smears on high-risk patients.
Right. The Anchor trial provided the definitive validation. It proved that actively screening for and treating precancerous anal lesions significantly reduces the progression to invasive anal cancer.
So it works.
It absolutely works. But despite that data, the clinical infrastructure for universal anal cancer screening is still in its infancy compared to the robust, decades-old protocols we have for cervical cancer.
Just lagging behind.
Yeah, establishing that preventative infrastructure is the next major public health hurdle for this specific anatomical region.
Wow. We have covered incredible ground today. We took 3 simple root words, procto, recto, and ano, and uncovered a hidden, highly complex world. We saw how ancient dissections of pigs and dogs gave the human rectum its deeply flawed name.
The straight intestine.
Right. We explored the high-stakes border dispute of the rectosigmoid junction, where medical societies argue over the very definition of an organ. We mapped the embryological collision of the dentate line and saw how it dictates our experience of pain.
We covered a lot.
We debunked the massive myth of the digital rectal exam, and we learned how one surgeon's dedication to a microscopic fascial plane cut cancer recurrence rates by 2/3.
But, before we close the book on the plumbing, there is one massive structural reality we have to acknowledge.
Ooh, what's that?
Well, we've talked about all of this as a terminal exit tube, right? But those root words, ano and recto, they actually extend far beyond the digestive tract itself.
Wait, they do? How so?
If you look at the wider muscular floor of the human pelvis, you find massive hammock-like muscles with names like the levator ani and the puberectalis.
Oh, named after the anus and rectum.
They literally take their names from their structural connection to them. This terminal digestive anatomy doesn't just hang loosely in the abdominal cavity. It is physically inextricably woven into the primary musculoskeletal floor of your core.
That makes so much sense.
These anamuscles are what maintain the structural integrity of the pelvis. They are critical for core stability, and they are frequently the exact muscles torn or damaged during severe childbirth injuries.
So the digestive system and the musculoskeletal system are fundamentally sharing the load.
Exactly. You cannot separate the digestive exit from the structural integrity of the human body. They operate as one integrated, continuous unit.
That just reframes everything we've talked about today. The borders aren't just blurry between the individual organs.
Yeah.
The borders between the major bodily systems themselves are completely intertwined.
It's all connected.
The body isn't a series of isolated plumbing tubes running through an empty chassis. It is a deeply interconnected web where every single structure relies on the one next to it. Well, thank you so much for joining us on this deep dive. We hope you leave with a newfound respect for this often taboo anatomy and a much sharper understanding of the complex map inside your own body. Until next time.